This is Today in Global Health, and it's brought to you by Astimid. And we get the show started. I'll tell you a bit more about Astimid shortly, how important a role it plays in your health. But let's get our guest on board this morning. We cannot start the day we have today in global health, without a certified, globally recognized professor joining us. That day, I don't know what will have happened to the day in global health. So let me start the show letting you know that all the way from Canada, Professor Uche Ungwaba is joining us. Good morning to you.
Good morning, Kyle. It's a pleasure to be here today.
Great, great. Good to have you join us today. And it's another great time to be here on radio having this conversation. How's Canada today?
Oh, Canada is good. Good. It's very cold this morning. We're right around the period where winter is knocking on the door.
Yeah, that's it. That's it. It's let's see. We are still fighting the rain. I'm praying for early Hamatan. So your winter will be a Hamatan. I will manage that. But, but it's good to have you join us this morning. Before we get into the topic, what we're looking at today, because it's all about health. But before we get into that, let's do a quick recap of what the week has been like, the last week
Yes,
conversation.
yes. Thank you, Kyle. So last week we had on Dr. Alan and Dr. Catherine Zeki. I'm not sure if I pronounced that correctly, and Mr. Alan Malache from Kenya. And both of them joined us to discuss addressing the obesity crisis, the rising obesity crisis, and unhealthy diets across Africa. Dr. Catherine, who is part of the NCD Alliance, was able to, inform us of some of the advocacy and works that are taking place in the area of, the push towards regulating the diet system or ecosystem across the continent, but particularly in Kenya, where she is based. A startling revelation that came out of the discussion last week was the fact that in Nigeria, we're still far behind in regulating unhealthy diets, and that we had an obesity issue. But then beyond an obesity issue was also the food safety issue that we flagged during the conversation.
Hmm.
We also heard from Mr. Alan Malachi around some of the, quite progressive steps that Kenya has taken, and that could be an example for Nigeria and policymakers thinking about front of pack labeling so that people can have a better sense of what they are consuming when they go shopping. But yeah, so that was the conversation last week, and that segues into where we are this week. And I'll let you introduce what we're talking about this week.
All right, so this week we extend the conversation just a bit further. Every week we bring you something more engaging, something new that we all can learn from. Today, we're getting into health finance, and talking health finance today, let me just make that a bit more explicit. Health financing, who pays for health in Nigeria? Who should pay for health in Nigeria? So two questions in one. First, who pays for health in Nigeria? And the appropriate question of who should be paying for health in Nigeria. I'm sure when we talk about that, one thing a lot of Nigerians will think of is, maybe a beneficiary, but you get in more details on what we mean by who is paying, who should be paying, and maybe even discuss how should the payment be made. But as we get into that, let me also let you know that in addition to Professor Uche Ngwaba, we also have a seasoned global health professional and a social impact strategist who's practicing at the nexus of public health, global development, and management system. That is Dr. Victor Iharo, who brings 20 years experience working with organizations, institutions, and countries across Africa, Asia, and North America, translate research into high impact strategies, policies, and programs that deliver systems level change through inclusive development models and innovative financing. Good morning to you, Dr. Haro.
Hi, good morning. I'm Kayode, and good morning, Nigerians. It's always a delight to be here.
Great, good to have you join us as well. And Professor Uchechukwu Gwaba already, as you know, is an assistant professor at the Lincoln Alexander School of Law at Toronto Metropolitan University and is also managing partner at Massfield LP, a transnational law practice with offices in Lagos, Abuja, and Toronto, Canada. He's been in this field, of course, legal and health, practice, worked in Australia, currently works in Canada, and right now he leads a program of research focused on advancing a regional health governance approach in inter-American and African human rights systems, respectively. Once again, gentlemen, good morning and welcome.
Thank you very much.
Great. So let's get the show started. When you talk about, I would like to simplify everything, not just for our professionals, but more importantly, for our listeners who might not have the legal understanding or understand the jargons, the health jargon. So when you say health financing, what do you mean?
Thank you. When we talk about health financing, we are referring to the process that takes place when someone is trying to access health goods or services, and you have to pay for those goods and services. All right. That is the process of financing. You go to the hospital, you have an emergency, and you have to receive care from the hospital. Do you pay for your treatment from your pocket? Do you wipe off your accounts to pay for your treatment? Do you set up a GoFundMe if you have to have like a kidney dialysis? We had instances where several stories of prominent Nigerians who, when it comes to time for their medical treatment, suddenly they have to set up. Somebody has to set up a public appeal through like a GoFundMe page. Many of our very famous
Celebrities,
movie stars, celebrities,
yes.
You name them, or they will start reaching out to prominent Nigerians to say, "Hey, you should take up this bill, contribute to this person's situation." That's the reality, and I think we have sort of normalized that in Nigeria, and as a way of life, as that is the way things are. If you fall sick and you have a very serious health bill, you say it's tough luck. And for many Nigerians who do not have the clout or personality to be able to attract the sympathy of the general public, well, they are left with prayer houses. They are pastors, they are imams, they are Okija Shrine or whatever they believe in. So this situation, I think it is worth situating and grounding it within a framework. The World Health Organization, which is the body that is, at the pinnacle of health governance globally, says that anyone who spends more than 40% of their income on out-of-pocket health expenditure is experiencing catastrophic health spending. So in case you don't know, catastrophic is a very bad word. So the WHO says if you get sick and you have to spend up to or more than 40% of your income at the spot to pay for your healthcare need, you are experiencing catastrophic health spending. Now, that is the reality of, I would say, 99% of Nigerians, except the very lucky 1% who have, generous health insurance coverage, either by their workplace or by their political office. So the 1% who get to, get free medical care by virtue of elected position they got into. And so what you have in Nigeria is a paradigm where there are two realities. There is the reality of everyone else, and then there's the reality of the 1%. Everyone else, don't get sick. That's the mantra. If you get sick, Nigeria will happen to you. And maybe on later episodes we can talk about other things with the health system. I've been following the news in Nigeria and seeing all kinds of negligence, malpractice, violation of patient rights. Maybe that's a conversation we'll have another day. But for
Mm.
today, we're talking about how people pay for health, because anytime I think about the Nigerian healthcare system, I'm troubled. My soul is pained. But for now, let's focus on the healthcare financing infrastructure. So anyway, the story I have teased out, the framework I have teased out gives you a picture of where we are at in Nigeria. And may I quickly add before I, stop at this point, that this is not ideal. This is not normal. In case you're thinking that this is how it is in other parts of the world, or in case you think that this is what the normative framework, on, the right to health, which is Nigeria is a signatory to under the International Covenant on Economic, Social, and Cultural Rights, an international treaty, and under many other instruments, soft law instruments and hard law instruments from the international context, and even within the African human rights context. All of these things that I've teased out are unusual, they're abnormal. They reflect Nigeria's violation of the rights to health of the average Nigerian. So I'll just stop here for now.
Okay, before I go to Dr. Iharo here, you've spoken about the fact that the statistics you gave or the definition you gave, which is if you're spending more than 40% of your income, so your monthly income or annual income, so if you're earning 100,000 and you're spending more than 40% on health every month, it means that you are living a catastrophic life.
Yes.
I laughed, there because there are many parents who earn 150,000 monthly, and every month the amount they spend on either preventing a health breakdown or on their kids occasionally from time to time when they fall sick, they even need to borrow money to fend for that. But before we even get into all that, as it stands now, beyond the alternatives that exist or the other options of funding, which we'll get into during the course of the program, the cost of health and the idea of healthcare in Nigeria, is it synonymous to Nigeria? Is it restricted to Nigeria, or it's a global standard to mean that is health normally this expensive? Is it this draining if you were to go it alone? Or are there things that we're doing wrong in Nigeria that is making our healthcare expensive? I want us to have that understanding before we begin to talk about the other options.
Okay, thank you very much. And let me just say a bit, and then I'm sure Dr. Ivaru will have something to say about this. Now, the fact of the matter is that health care in anywhere, in any part of the world, is a very expensive enterprise. When you leave healthcare to the citizenry, then that is tantamount to an abdication of a core and fundamental responsibility of government. In civilized societies, in societies that have a heart for their population, for their citizenry, government invests so much in terms of social programs to address issues around access to health. Nigeria, and of course, Nigeria is not alone in this bracket, and countries that are like Nigeria, stand alone in leaving their citizens behind. And so the question then becomes, if Nigeria shouldn't be doing this, what is the ideal context? Well, the ideal context, let me use the context of, for example, Australia, a country I lived in for about 8 years, where over 50% of the GDP is invested in health or allied health areas. That is, when you ask what is the driving consumption or investment focus of the government, it is health or health-related areas. There are all kinds of buffers that have been put in place by the states to ensure that citizens have, at a very minimum, the ability to access critical health needs, health goods and services when they need them. Same thing too in Canada, same thing too in many other progressive societies, where health is not left for the citizens alone. It is a social good which the government has part of its core function or responsibility has an obligation that is confirmed by law to invest heavily in. And so what we have in Nigeria now is the fact that healthcare is left to every man to take care of, using the biblical saying, to your tents, O Israel. So every man, you're on your own. No one cares. Government does not owe you anything. If you fall sick, that's on you. You should have been born better. In your next life, come back more healthy. That's almost the attitude you get a sense, unless you belong to the 1% that I mentioned. And maybe, Victor, you probably have something to add to this.
Yeah, absolutely, Professor Uche. I think you wouldn't have, no one could have said it better. The situation in Nigeria is really dire. What we experience in Nigeria regarding healthcare is not just a catastrophe, but it's an unfortunate situation. And my approach to this conversation around healthcare, I would try to approach it from two perspectives, right? The up top to the bottom and the bottom to the top. Let me approach it from the top to the bottom, which we started talking about. Every citizen is a property of the government. Every single human being, every citizen is a property of the government. And when I say property, I say that lightly, not to demean the value of human life. But what I mean is, once you are born in Nigeria, the government has a responsibility towards you. And that's why every citizen has a right to health as a fundamental human right. That's one. Number two is that access to health is not a privilege. It's a social good that is obligated by government to provide to every human. So what that means is that if peradventure somebody else threatens another citizen within the country, threatens the health of another citizen within the country, it is the government's responsibility to make sure that that doesn't happen. It's the government's responsibility to make sure that everybody that shows up in a facility receives health care, so long as that facility is under the governance structure system within that state. When I mean state, within the government system, whether at the federal, state, or local government level. So what we have currently in Nigeria is a broken system, a system that where government may not have even recognized what their responsibility is, just like a parent having children and they ask the children to go take care of themselves. And when you ask the parents, why are you asking your children to go take care of themselves? They tell you, what's my business? I don't have any business with those children. That is what the situation is. But let's bring it home a little bit and really analyze what's the practicality of financing health in a place like Nigeria is. So many years ago, about 2001, African Union countries recognized that it was important for them to put aside certain funding for healthcare, as a moral imperative, but even as a constitutional provision, right? And so they came up with this very beautiful document that they call the Abuja Declaration, and I'm sure many of us have heard about the Abuja Declaration. And that beautiful framework and agreement was signed by all the 63 AU member countries. And the provision within that declaration is that 15% of the country's revenue must be allocated to healthcare. You talk about a country like Australia that is allocating 50%. This is African Union countries just saying, you know what, let us put aside 15% of whatever it is that we earn as a country to cater to the health of the citizen. And that was, even to put it very modestly and lightly, right? And if you look at between 2001 to 2025, that is 24 years after, many countries are still struggling to meet that target, right? In fact, to make it worse, Nigeria hasn't met that target. Current funding for health, averagely, national average still falls below 1%. It's actually about 0.65%.
Mm.
Um, and there have been many other frameworks and recommendations that have been proposed around how to, in what we call ring fence. Ring fence means put aside certain funding for health. Different kinds of interventions have been proposed, from the Saving 1 Million Life Fund, which is an World Bank intervention to say, you know what, government, if you do certain parts, I would also give you certain money. If you meet certain conditions, I will put certain money aside.
Mm.
Those are some of the interventions. Recently also the Basic Healthcare Provision Fund, was proposed as a way to fund basic healthcare. Basic healthcare is healthcare within your community such that everybody can have access within a certain radius to health services when they need it, emergency health service. And they said, you know what, let's put aside 1%. That's the basic healthcare provision fund. Let's put aside 1% of our consolidated revenue. That's all the money that the government makes as revenue, tax, sale of crude, and
Mm.
all form of revenue. Just 1%, just 1%. We'll put that aside to fund basic health services. And as much as that framework has been on for a couple of years, it is still an ongoing debate, and a lot of advocacies is ongoing to ensure that government fulfills that requirement.
Mm.
And it's still a struggle. So you see, we have come a very long way from 24 years ago in the Abuja Declaration, where it was agreed, and Nigeria signed that document. They had their signature on that document. It was agreed that let's put aside this amount of money for health. 25 years after now, we are struggling to have 1%, put aside for basic healthcare provision fund. So it's a big problem, right? It's a big problem. Now, let's come downstream a little bit. Um, when you look at the issue of out-of-pocket expenditure, which Professor Uche talked about, right now about 90% of Nigerians fall in that bracket. You're talking about um, people shouldn't spend 40%. 90% of Nigerians are spending out of pocket. Actually, it's only about 10% that have any form of insurance coverage, which means that if there is a health emergency today, 9 out of 10 Nigerians will go into crisis. So we are all catastrophic.
Mhm.
Majority of us are. So if you see your neighbor on the street, just give them a high five and say, "Hey, catastrophic, what's going on?" Right? That is the situation we have,
Catastrophic
right?
neighbor.
Catastrophic neighbor. And let me even shock you. Somebody can be healthy for 20, 30 years
Mm.
and has put up all their savings, and just one
One
incident can wipe
illness.
all of those away,
Yes.
right?
Yes.
People sell
We've
their
seen a lot of
houses.
that in Nigeria.
It is, I
Yes.
mean, it is terrible. So why shouldn't we do stuff about, and also maybe just to rest on this point, what also makes it worse for Nigeria and Nigerians is that when you combine the social determinants, what we call
Mm,
the social determinants, the social issues that we deal with,
mm,
you're dealing with issue of employment, you're dealing with the issue of access to clean water, you're
mm.
dealing with the issue of road network, access to road network. You're dealing with
Insecurity.
insecurity. You're dealing with so many issues, where the basic issue like being able to sleep in your house with your eyes closed and you're not jumping out of your balcony is a big problem from Nigerians. Then you just know that you would likely fall into health emergency one way or the other, you know. So I think I would like to stop there because there's also another dimension of where there's access, people cannot reach it. People in government is investing in healthcare. We have trained doctors, we have trained nurses. Almost every corner you go to, there's either a clinic, privately or publicly owned. But you go there, services are not available, or you go there and even in emergencies, and it's really sad, it's really unfortunate.
Mm.
I think those of us in the medical profession have also failed the system. The system has failed us, and now we are failing the system. Where somebody is dying personally, I've had the opportunity to take people to hospitals, government hospitals in Nigeria, and I introduce myself as a medical person, and they refuse to attend because they ask for, how do you ask a dying person to bring ID card, bring money, bring bank? I mean, how do you do that? It seems that we've
Very
lost our
embarrassing.
soul, even as a nation. We've
Mm,
lost
Mm.
what we proclaimed as medical people.
yeah.
We've
The
lost
essence
it.
of our humanity.
The essence of our humanity is gone. And like I said, in previous episode, I said the path to fixing Nigeria is that we should be humans first.
Mm.
That is just the first thing we need as Nigeria. If there's going to be a Nigerian project, it should be the human Nigerian project
Mm.
Mm.
because we've actually lost our soul, we've lost our essence, and it cuts across the fiber of society. But you also will not blame the medical professionals because when they actually deliver that care, who is going to pay for it? When there's no social protection, the
Mm.
person does not have money, the person does
Mm.
not have insurance, and you dispense care, you have staff to pay, you have drugs and commodities and consumables to replenish. So you see, it's a vicious circle, and it's like we're in a tornado. The more it's going around, and we are digging ourselves into the hole, and it's sad. It breaks my heart, and I'm sure it breaks the heart of many
What
Nigerians,
comes
especially
to
of those
mind?
of us.
What comes to mind as you spoke is the expression, a cataclysmic catastrophe,
Yes.
because
Mm.
it's gone beyond just a catastrophe.
A
Yeah.
monumentally cataclysmic catastrophe.
Because and I'm sure a lot of my listeners who could be very sensitive will say, "Why are these people laughing?" We know it's a serious matter, but at times
Yeah.
This is
you look
better
at
now.
things and you just need to. Because while you spoke, I was thinking through it. The US, for example, they have about 6,000 or almost 7,000 hospitals. In Nigeria, there are reports that we have over 40,000 hospitals or healthcare facilities. Yet we are unable to provide the kinds of services that a nation with 6,000 health facilities provides. Doesn't that on its own, isn't that an indication on its own that there's a problem? Because what then do we call a health facility? If
Mm.
40,000 cannot outdo or outperform almost seven, let's even say 7,000.
Mm.
Isn't that I mean, and you're not talking of providing all this other services, but when you look at this, health insurance was introduced in Nigeria, I think around 2006 or 2007.
Mm.
It was introduced in Ghana around 2005. Ghana had challenges. I've said this a couple of times on radio. Ghana had challenges with its health care. I mean, it was rejected, facilities turned it down. But fast forward till now, it is catering for a larger number of people, I think, than that of Nigeria. Now, Nigeria's healthcare, what's it called? Health insurance has not worked that much compared to that of Ghana. Beyond health insurance, which other approaches or alternatives are there that will ensure we provide not cheaper, but as access to healthcare without strangling the people?
Kayode, we cannot move beyond health insurance because in societies that have gone ahead, health insurance has been the vehicle that has powered that progress. The WHO has the framework called Universal Health Coverage, which is a framework that has set an ambitious target that by 2030, no one should be left behind. Everyone should have coverage of some sort. And it's also part of the Sustainable Development Goals. Goal 3 of the SDGs says that universal health financing should be a priority of government. Now, the idea behind financing is really about pooling of risk. You mentioned the person who saves money and then one day they suddenly fall ill and everything is wiped away. If they have insurance coverage, what happens is that when that day comes, that rainy day, okay, insurance would reward them for their lifelong contribution through premium by making sure that those health costs that would have wiped them off, they are shielded from it. I can't tell you how many times I've routinely gone into to go and receive dental care here in Canada. and I don't pay a dime. They do all kinds of operation. There was even one day, they worked on my teeth for over an hour plus. I didn't pay a dime.
Does it mean they don't have other patients to attend to?
They have other patients. It's not like they're not being paid. When my insurance sent me, they said we have paid this person, this vendor who asked us to pay on your behalf. When I now checked the bill, I saw some of those services. One of them was about $800, $900. That's a lot of money because if people think you're trying to do the mental mathematics, you think, oh, 800 is 800 naira. No. At the going rate, at the going
like
rate, that is
1,002 per
800 at the current going rate. $800 is probably up to like 1 million. So imagine I walk into an establishment and I spent like 1 million naira just working on my teeth and I don't pay a dime. That's what health insurance has done for me. That insurance is insurance that comes from my workplace coverage. But then apart from that workplace coverage, even if I didn't have that, I still have the universal health coverage, the one that the government offers. Now in Nigeria, we talk about, yes, we have the National Health Insurance Scheme and all of that. And then you have some people who work in very, prestigious work environments who are, covered by, private plans. The average market woman in Nigeria doesn't have access to the Nigerian health insurance product. The informal sector worker, and the majority of Nigerians are working in the informal sector. The agricultural worker, they don't have access. There's no sort of facility that kind of captures them. We don't have a holistic coverage that captures, the populace. Here in Canada, as an example, once you, even as an immigrant, and you come here, the moment you arrive here, even without permanent residency, you have some sort of coverage. There's at a very basic level, some sort of coverage. The moment you're a permanent resident, you have full coverage under the Canadian Universal Health Coverage plan, which we call Medicare. You have a Medicare card, you have a Medicare number. When you go to buy a drug, they say, oh, I want to pay for this drug. They say, oh, the drug is $100. Do you have a Medicare card? You say, yes, here's my card. You give them your card, they scan it, they do whatever they do. They say, okay, your balance, what you have to pay is $20. So you walk into the store, you were going to pay $100 for a drug, you end up paying just $20 because of the Medicare card. In other words, what has happened is that a transaction has taken place where the vendor has been able to access a pooled funding that has been set aside for purchase of drugs to make drugs more to subsidize drugs for the citizenry. When last did you hear that, as part of the federal government budget for health this year, we have subsidized XYZ number of drugs. So all Nigerians can access that drugs at a very, very affordable rate. When was the last time you had?
No, it's good you said this. That's why I asked about, is there any other alternative? Because, for example, in Nigeria, I think the National Health Insurance Act, I should download it and read it again. It makes it compulsory for every state to have a state health insurance, a body or scheme. Now, it makes it very compulsory. It has made the health insurance of the state, or is it federal, compulsory for every worker. I think every worker with over, 10 staff or so. A lot of people do not abide by that, which means you must get the state or also get the local or any other private one. Now, for example, Lagos State LASHMA, they have one insurance that is meant, a scheme that is meant for the market women and something, eco something. I can't remember the name now. Now, all this is there. A lot of people are not buying into it. There are organizations that are breaking this rule. But beyond that, the last statement you said now is why I interjected that, is it possible, like what we've seen government do over the years, although not transparent enough, for government to say, okay, listen, while we're trying to get a lot of people to buy into the idea of paying money ahead, because anything we're paying for, even car insurance, except you put a gun to our head, a lot of us don't want to pay, because I won't have an accident in Jesus' name. I won't fall sick in Jesus' name. I'm protected, I'm healed. By his stripes, I'm healed. We prophesy, we declare all this. So is it possible that government can say, while we're trying to implement this and get the people to support, we are providing subsidy in different areas on these very maybe some of the most frequent or common diseases. We're providing drugs. For example, malaria now in Lagos is free. So anywhere you go to, especially the government hospitals, and you are charged for malaria, I'm saying it on air, it is free. I took my daughter to the hospital about 2 days ago or last week. I was given 3 medications, and the pharmacist himself, he really said, this is a malaria tablet. It is free. You're not paying for this. These are the ones you're paying for. But I'm not saying federal government paid that. I don't know if all these foreign partners brought that to bear. But beyond the insurance, can subsidy and other interventions in some rural communities by the state government, the local government, the federal government, can that also play a role in reducing the cost of healthcare?
Certainly, certainly. But then what is interesting is that these subsidies you mentioned, it's a form of insurance because people always think that insurance has to be, just essentially always privately funded. Because even when you refer to the Canadian scheme, as I mentioned, that's the question is how is it funded? Of course, it's funded by taxpayer money, but then it's also funded by the government making also reciprocal contributions into the fund, into the pool of funding. The point is that there is a safety net that has been created that has a coverage across the entire Canadian populace. Of late, the preoccupation of the Nigerian government after government, has been collecting people's data. Today it is NIN, tomorrow it is BVN, all kinds of registrations and collection of data and details are taking place. What is the value of your NIN card? Your NIN card right now in Nigeria is only valuable for like maybe identification purposes. But in reality, your NIN card should be the access to social services, including healthcare. You should be able to say, when I have my NIN PIN and my NIN number, I can be able to go to hospitals and access subsidized medical care. And so, in other words, the value of Nigerian citizenship, because at the moment, when I think about it very critically, I ask, what does Nigeria do for her citizens? The average Nigerian, I'm not talking about somebody who God has buttered their bread. They have somebody in power. I'm saying the average wheelbarrow pusher.
Who has no access.
In Ogba Market, who has nobody. What does Nigeria do for that person? When you think really hard, Kayode, you discover that you might actually be hard put to find any single thing that Nigeria does for them. Because even in terms of securing lives and property, Nigeria doesn't do a good job of that for the average Nigerian. The value of Nigerian life is very, very cheap. So back to the point I was making. The point is that what you have described as an alternative scheme is actually part of the framework of health insurance, because health insurance is government contributes, citizens contribute, taxpayer money, everybody that is working, there is a contribution you're putting into the scheme. Now, you said Nigerians don't like insurance. The reason why Nigerians don't like insurance is because they have never seen insurance work.
Yeah.
When I was in Nigeria, my knowledge of insurance is there are these people who they'll ask you to pay money. When it's time for them to pay, they will look for reasons not to pay. That was my knowledge of insurance. Until I came abroad and I realized that you cannot, in fact, as a Canadian, as a citizen, I am uncomfortable if I'm not paying my insurance, because I'm thinking if something happens, I'm screwed. I need insurance. So insurance is that safety net I have. When I think about anything that can go wrong, it's okay, I have insurance. So until we get to the point where Nigerians are acculturated into seeing that there could be some kind of social safety nets, both from the government and from private and insurance is big business. It's big business where it is properly utilized. It can be a driver of our economic, growth. So let me just let me rest on this point for now.
Doctor,
yeah, maybe just to quickly weigh in on the conversation. Coyote, insurance is the way out of the problem. And I to also cut the government some slack, to be honest. I have had the privilege of working across the length and breadth of the country, from the north to the south, in the course of my public health work. And I can say for free that there are a number of services that are available free. In fact, I have been in many communities where services are available free in the primary health facility, but the people don't even know
Mm.
and the people are not assessing it. I had the privilege of managing global supply chain programs. And year after year, some of the problems that we have, while we are dealing with the problems of stock out on one hand, we are also dealing with the problems of expiries on another hand,
Mm.
because, people are not taking up services. So it boils down to the issue of one, awareness, two, trust, three, accountability. That's just the way it is, right? For awareness, people need to know what services are available. They need to know where to go to for those services. They need to know per time what to expect when they show up in the facility. So if you tell me that the service is available, for example, there is in terms of the primary health at the primary health care level, if you go to most primary health care facilities that take deliveries, women should be able to deliver for free in those facilities. If there's a health emergency that is related to maternal and child health, people should be able to, any child under 5 should be able to access services free in most primary health facility. And I say this from the point of my experience as a public health a practitioner, having worked at primary healthcare level across the country, right? And I'm sure we have quite a number of organizations, accountability organizations that are out there in the communities, watching out for the implementation of all of these things. And I think it's also good. Maybe we can have a conversation with some of these community-based organizations so that they tell us what's really going on ground. But from my standpoint, I know some services are available. The other thing I also wanted to say is that when you go to some of these facilities, even though service is available, we need to talk about what is the quality of the service,
Mm. Mm.
right? Because you say a service is available, I show up in the facility, right? There's no diagnostic tool. Yes, you have a healthcare worker at whatever cadre based on the facility, but you don't have diagnostic tools, you don't have commodities, you don't have power. Women still give birth in this country with candle.
Mm.
Doctors still perform CS and surgery with touchlight phone on their head. That is how terrible it is. Many facilities do not have access to power. They don't even have access to water, to pipe-borne water. So when you're talking about you go to the hospital because you're sick for one thing, but you come out with hospital-acquired infections. You come out with other complications, from botched surgeries, that maybe not intended, or you come out dealing with some form of additional catastrophe, if you like, right? So I think just to cut that slack, to say that in many primary healthcare facilities, some services are available. Now, let's bring it home to the issue of insurance. I would always give credit to the new dispensation in the National Health Insurance Agency. In 2022, we know that there was an evolution of the National Health Insurance scheme, which
Yes.
now legalized that framework, making it a National Health Insurance Act, right? And within that act, there are provisions for taking care of vulnerable people, where services are available for free. There are provisions for taking care of the elderly and children. There are provisions for those employed in the public sector. There are provisions for those in the informal sector. There are provisions for those that are privately employed that also want to engage in private health insurance services. So these provisions are there. But what is wrong? Why then is the uptake slow? One is like Professor Uche said, we're not using our data. We have data. The problem with Nigeria is not data. If you want to know that Nigeria has data, is that offend a politician or offend
Mm.
somebody in government, they will find you. I believe that Nigeria has one of the best security systems in Africa, to be
Yeah.
honest. If they want to do what they need to do, they can do it because they have data. We have data. So the question is, why are we not using our data? What is happening to our social register? Right? We keep hearing of all kinds of schemes, programs. They are giving out this for vulnerable people here and there. But I go to my village and I ask people on my street if they have ever received any of the vulnerable interventions, and they say no.
Mm.
During COVID, there were data saying, oh, they did all these kind of interventions. But if you go to my grandmother in the village, or you go to people, just go to rural communities and ask them if they received any of those intervention funds. They'll tell you no. So on what basis are some of these things being distributed? On what, how are we using data like the NIN, right? Like the BVN? Why can't we integrate insurance within the framework of our existing data? Almost every working person, even business people, have bank accounts, and those bank accounts have BVN and NIN linked to them, right? Every passport holder has their passport linked to their BVN and their NIN. So why can't we integrate data to ensure that we make health insurance coverage compulsory? Because really, it is compulsory. They call it mandatory, which means that you can opt into it. But as a matter of fact, it's something that all Nigerians should have. And finally, I also just want to mention that the issue of trust is a big problem, right? You can only invest in what you trust. If I know for sure that I am making this contribution, even if I don't experience any health catastrophe or any health emergency, I can access preventive services. Professor Oche talked about going for dental care. 2 weeks ago, I went for dental care and they gave me a bill of about $800. Last week, my daughter had a temporal tooth that was growing alongside her permanent tooth. You know, just to pull out that temporal, it was already wiggly. It's almost going off. Just to remove it, I spent $250
Something
just
a
to remove.
Nigerian parent will have done with a slap.
It's no, of course, health insurance covered it. Health insurance covered it. But what I'm saying is that, with health insurance, that's the beautiful thing about health insurance. With health insurance, you can even walk into the facility based on your coverage to say, just check me. I just want, I just check
I
just
just
make sure
don't. I
everything.
just they
You
feel
don't need
one
to
kind.
wait. Yes, you don't need to wait until you are sick
That's it.
before you access care. So what is happening to Nigerians is Nigerians are delaying the initiation of care because of the cost associated with it,
Okay.
such that by the time they initiate care, it is too late.
Too late.